You all for being here on a Friday afternoon at 4 p.m. You guys must be very committed to South Asian studies and to the U of M. It's a pleasure to give a talk to this audience. As you know, we don't seem to get out of our academic walls that much, our silos that much. So to be honest, I haven't spoken about my research to a humanities audience that often, maybe to the public audience, but not to the humanities audience. And you may know a lot more about India than I do. You most likely do. Just a little bit more about my background. I was born in India. I lived in India until I was 8 years old when we emigrated to the US at that time. So I have lived a life where I was, living in two cultures in many ways, trying to define my identity through my adolescence and my adulthood. And in doing my PhD in public health, I was always drawn to doing work in India. My thesis was on India and pregnancy care in India in rural populations. And after my PhD, I did a postdoc in cancer control and prevention and got interested in tobacco control research. And I started tobacco control research in California, where I got my PhD in UCLA, where we looked at neighborhood kinds access to tobacco products and promotion messages and anti-tobacco messages and their impact on tobacco consumption in young people. And so I kind of moved away from my work in India while I was doing my postdoc, and I said, I want to bring some of these things back to study some of these things in the Indian context. So I looked at asked the hypotheses that I was testing in the California setting and see if they played out in an Indian setting. And that's when I applied for the Fulbright Narrow Fellowship, which is what I'll be presenting on today, the data I collected during that fellowship, to look at tobacco control policy implementation in local settings, in community settings, and to understand how that might be related to tobacco consumption in young people in India. And I did that work in Bombay, or Mumbai, as it is called now. I still call it Bombay because that's what I called it when I was a little boy. So tobacco use in India. I just kind of want to give you a background about why we want to look at tobacco consumption. So look at tobacco consumption in a global context and a global health context. Why is tobacco use of importance for public health and health? And also look at some tobacco control policy strategies that are implemented across the world. We'll talk a little bit about the WHO Framework Convention for Tobacco Control, which guides a lot of policies that member states take on. And then we'll look at India's application of the FCTC in some sense. And then we'll end the talk with how that might be related to tobacco use in young people in India. Okay. So this chart goes, the time axis here, I would say maybe you could think about here as being the 1900 or so. And we're probably right smack in this third of that axis. And what seems to be happening globally is that the traditional risk factors for death and disease are becoming less and less important over time. Right? Traditional risk factors is things like sanitation, air pollution, access to clean water. Those types of things are becoming less and less important. What's becoming more and more important are things like tobacco consumption, physical activity levels, sedentary lifestyles, consumption of high-fat and high-sugar-free foods, those types of things that drive chronic diseases, right? So chronic diseases are going to be more and more important as time goes on. And one of the greatest contributors of chronic disease is, of course, tobacco, right? Tobacco is the #1 cause for death and disease worldwide. This kind of illustrates that more in terms of causes of death, disease-specific causes of death. So as time goes on, cancer, right, heart disease, strokes, those are going to be the major causes of, they already are, and they continue to grow. And the traditional causes, as we call them, caused by infectious diseases or lack of access to clean water, things like that are going to be less and less important, relatively speaking, over time. It's not to say that these are not important things. These are very important things to tackle. But what's going on now is that these chronic diseases are becoming more of a burden. And a lot of countries are facing a dual burden, right? India is facing a dual burden where they have to deal with these chronic diseases and a high burden of death and disease from these other causes at the same time. So many nations are having to grapple with this dual burden right now, which makes it a big challenge. And what seems to happen is chronic diseases are really not as well addressed. If you look at a lot of public health activities in India, they're still focused on sanitation, access to maternal care, childhood survival, and those types of things. And less resources are focused on things like tobacco prevention and control, improving diets, improving physical activity, and so forth. And this slide, it talks about, we think about tobacco as an agent that causes cancer. But cancer is really only 1/3 of the diseases that tobacco is responsible for causing. Right? Tobacco also causes respiratory diseases, cardiovascular diseases, digestive diseases, is linked to diabetes. So there's a host of diseases that tobacco is responsible for. And that's why tobacco is one of the major contributor for death and disease in the world, because it's linked to so many different systems in the body. Right? So just to drive this point home even further, in the 20th century, about 100 million people died because of tobacco consumption worldwide. In the 21st century, about 1 billion people are expected to die of tobacco consumption. So that's about 1/7 of the current world population. It's a huge, huge number. Yeah?
So, quick clarification, what do you mean by tobacco use and tobacco consumption? Do you just mean smoking?
No, I mean so smoking, chewing, snorting. Now we have the new form of vaping, vaporizing tobacco. So it's all of those things. And a lot of the estimates are on cigarette consumption, mostly, not even other forms of smoking tobacco. So this might be an underestimate of the actual burden of tobacco consumption worldwide. Because, a lot of the data that's being collected is about cigarette use. We don't collect data on things like Mistry or Gutka or, or all kinds of additional other traditional smoke-less forms of tobacco consumption. So, these 10 countries represent the countries that are the highest users of tobacco worldwide. Right? 2/3 of tobacco smokers worldwide come from these countries. And India is the second largest smoker in the world. But if you add the smokeless tobacco form to this data, which we don't have actually, India was probably going to rival China as the #1 tobacco consumer worldwide. Right? So as a result, India faces a disproportionate burden of disease and death due to tobacco consumption worldwide, and that's why we need to focus on that in that population. In terms of production, India also ranks pretty high. India is the 3rd largest producer currently of tobacco worldwide. China outpaced everybody since the 1970s. And in China, tobacco is a government-owned business. And so China is having a hard time removing itself from that market. So what is the world trying to do in terms of dealing with tobacco? Policy strategies are the main tobacco control strategies in place right now. Education as prevention is probably not very effective. There's a lot of studies out there looking at educational programs which tend to not work that well, but smoke-free policies tend to be very effective. Policies that limit advertising and promotion tend to be very effective in reducing tobacco worldwide. Limiting access to tobacco in young people is an important policy strategy. And pricing, taxation, is a critical public health strategy for limiting tobacco consumption in populations. Now, the FCTC, which is the Framework Convention of the World Favorite Convention for Tobacco Control, which is a treaty of the WHO, tries to get member states to kind of corral around these sets of policies and try to implement them. So the treaty was the first health treaty that the UN has actually put together and ratified and had member states sign on. And this was ratified in 2003, not that long ago. And the mission of that treaty is to protect present and future generations from the devastating consequences of tobacco consumption and exposure to tobacco smoke. And it regulates the lobbying, production, sale, distribution, advertisement, packaging, taxation, and research around tobacco. Now, just because you sign on to these treaties, as you know, they don't really have any meaning unless member states ratify or enact legislation that is in line with that treaty. Right? So India was one of the first signatories to the FCTC. And immediately in 2003, it passed what is now known as the Cigarette and Other Tobacco Products Act, which was working to be in line with the FCTC. So India was recognizing the importance of tobacco control, right? Immediately getting on board with what the global community was doing around tobacco control. So now just a little context about tobacco use in India. About 35% of the adult population uses tobacco in India. About nearly half of all adults use tobacco of some form regularly in India. And I'm sure many of you have been to India chewing tobacco. You see tobacco being spit almost everywhere in form of pan or pan masala in variety of different forms. And 1/5 of females, adult females, use tobacco in India. In terms of youth, this is data on just 13 to 15-year-olds. Let's see, about 12% of youth are using, it's not just 12, it's 12 plus 3, right? So it's 15% of youth are using tobacco in India. And of course, more boys than girls are using tobacco. And cigarette, as you can see, is not the main preferred mode of consuming tobacco in young people or in adults. And India is interesting because, as all of you know, there's so many different forms of tobacco in India. It's just not cigarettes. In the US, cigarette is the main form of tobacco used by far. So regulating it is probably a little bit more simpler than regulating, dozens of different types of tobacco products. I'm just going to go through a few of what they are. I imagine this audience knows them pretty well, but just to illustrate, we all know BDs. Pan masala, right? Pan, the betel quid, and the manufactured form of pan is very popular, as you all know. Gutka. Now, I'm not sure if you all know, gutka has been banned in about 26 to 27 states in India. And starting in 2012, these bans started to happen. Gutka is a particularly dangerous form of smokeless tobacco because it comes in lots of different flavors. It's packaged just like little candies, right? If you go to a little convenience shop on the street, you'll see the candies wrappers, and then you'll see gutka right next to them, interchangeable. So very dangerous form that young people are attracted to. And I did my Fulbright at a cancer hospital in Mumbai, Tata Memorial Cancer Center, and talking to oncologists there, they're saying we're seeing patients in their late 20s and early 30s with major precancerous lesions and full-blown cancers in their mouth and esophagus. This is very young to be developing this type of a cancer. Cancers usually take 20, 30 years to develop. But Gutka has been blamed for much of this because of some of the other chemicals to cause lesions in the mouth as you consume the tobacco. So lesions makes it easier for the nicotine to get to your bloodstream, but it also increases inflammation, which also increases your risk for developing cancers quickly. That's why it's been banned, but we don't know how well the ban has been working, right? Kaini is another form of chewing tobacco. Kiwan, these are usually things that are put in pan masala to give it a pan to give it flavor. Mawa, Mistry, which is just roasted and powdered tobacco. And as some of you may know, some folks in India believe tobacco is a dentifrice. It protects your teeth. So people do use it in the morning as part of their morning ritual. And as this woman is doing, and as a result, there are tobacco-laced toothpaste.
I can't help laughing, but it's awful.
Well, it is awful, but
Oh,
exactly,
God.
the wonder, pleasure of treasure of tobacco pleasure, yeah, and creamy snuff. So, just imagine having to regulate and enforce regulations around all these types of products, and many of these are homemade. You're not getting them in stores. So that's a challenge India faces. And now what we have is e-cigarettes is another form that's coming into India. It's a nascent market in India. It's just starting off, although e-cigarettes were developed across the border in China. India is not as far along in their use as we are in the US. So this is going to probably lead to new regulations. I think they're already talking about banning e-cigarettes in India rather than regulating them. So many different forms of tobacco. How does India kind of, what grade does it get in terms of following along with the FCTC in terms of implementing some of the things FCTC talks about? Empower is a strategy that the Tobacco Control Initiative of the WHO has put forward to get member states to be more congruent with FCTC. Right? So M stands for monitoring tobacco use and prevention policies. India does not honestly do a very good job of monitoring tobacco consumption and related diseases. So India has very few surveillance systems in place. These are just some. I'm not going to read them to protect people from tobacco smoke. India does a pretty good job of that. There is a smoke-free laws that are well adhered to and enforced in India. Offer help to quit tobacco. Very poor cessation services in for tobacco in India. To my knowledge, publicly free available cessation services in Bombay, there was only one, which was at Tata Memorial Center. There were no other place for poor people to get tobacco cessation counseling and drugs to help them stay off of tobacco. Warn about the danger of tobacco. So there are graphic labels on cigarettes and other tobacco products in India. Interestingly, in October last year, a new set of laws came to effect around warnings on packaging, which said 80% of all packaging has to have textual and pictorial warnings on them, which is pretty high compared to other countries. Enforce advertising, promotion, and sponsorship bans. So advertising for tobacco is banned in all places except at the point of sale where you purchase tobacco. So you can't promote tobacco at billboards or in magazines or on TV. And raised tobacco taxes. Taxes vary across products, and they're pretty minimal. 9% for BDs, about 38% for cigarettes, and the recommendation is that all products should be taxed over 50%. So a long way to go around taxation. What we wanted to do is to look at youth-relevant tobacco control policies of COPTA. And these are the policies as we examined in the study that I'm going to talk about. Prohibition of sale of tobacco within 100 yards of educational institutions. Prohibition of the sale of tobacco to people below the age of 18. And prohibition of marketing, direct or indirect, of tobacco products except at the point of sale. So we did a pilot study to see how compliant communities are around these issues, right? So what we wanted to learn was the feasibility of doing a population-based student tobacco survey and to collect field data on compliance and presence of marketing and tobacco vendors. We wanted to estimate the prevalence of tobacco use and individual level risk factors for tobacco consumption. We wanted to look at the density of ads and vendors in communities, and to look at compliance to youth-relevant tobacco control provisions. So, and look at association of better compliance of vendor-level factors. So we did this study in Bombay. You all know where Bombay is. Just to give you an idea, I guess I don't need to do this for this audience. A very dense and economically diverse city, right? So what we did was we did a population-based tobacco survey in students in India, in Mumbai. It was what we call a two-stage cluster random sampling design. We looked at 26 schools and collected data on 1,500 students over a Fulbright, right? So people don't do much on Fulbrights, I've noticed while I was there. We did mapped out all ads and all vendors around those 26 schools in a 500-meter radius. And then we conducted vendor surveys. A random sample of vendors were selected from those that we mapped, and we did about 400 vendor surveys during that year. So we used a handheld GPS, a computer with a GPS chip on it, to measure the tobacco ads and vendors. And these are the folks that I trained to do that. These are MSWs, Masters in Social Work. So I guess this is to illustrate that you can train people in a short period of time to collect a lot of data in India or anywhere. And this is a map that we made. In India, at that time, there was not that many base maps available with all streets. Right? Even if you use maps now like Google Maps, you may not find all the little gullies. But we wanted to go down every little street to see where kids can get tobacco. So we decided, well, we're not going to rely on existing maps. We're going to make our own. That's why this looks so rudimentary. It's basically, lines and dots. You don't have any other features on there. So this is an example of a school, right? We mapped the perimeter of a school. We mapped every street from the school, going about 500 meters outward. And the red dots are vendors. The black hash marks are ads. And you can only have ads at where you sell tobacco. So you notice some ads here that are not in vendor locations, right? So this is to illustrate the type of maps we created. And what do we find? We found that on average there are about 62 vendors within a 500-meter radius of a school. That's a lot of vendors. And the range was 2 to 200, right? Within 500 meters of a school, you can actually be exposed to 200 vendors. Within 100 meters, the average was 8, and the range was 0 to 28, which is quite a lot. If we did the similar studies in California, and we found that there were, on average, there's 11 vendors within 1 mile of a school, right? So just to think about what people are exposed to just walking on the street instead of tobacco promoting messages, and just access to tobacco, physical access, and tobacco is super cheap. In India. You can buy singles. You can buy 1 cigarette at a time in India still, which was banned in this country decades ago. Right? And these are the types of places you buy tobacco. Most of the tobacco vendors were general stores. You all know what these are, little convenience shops on the street. The other half or so were street vendors, mostly panwalas. And this is to show that you could, we saw kids buying something from a panwala while doing this study. And this is actually a young man, child, selling tobacco. He's working as a panwala in India. And this is a map of the data that we collected. The circles, the size of the circles represent the prevalence of tobacco use in the schools that we sampled. And the color represents the density of tobacco vendors. And if you correlate those two variables, you see about a 0.34 correlation between vendor density and school level tobacco use prevalence, which is not that high, but there is a positive correlation here. And it's approaching significance, which is of importance to us, that there is actually something important here going on. And our sample size was pretty low, 26 schools, but 1,500 students. In terms of ads, we saw 16 ads on average within 500 meters, and 2 ads on average within 100 meters. And the 100-meter zone is important because that's where it's banned to sell. There's a ban on selling and advertising tobacco, right? So we did find that in a lot of schools, their neighborhoods were not compliant. And this is just to illustrate some of the ads that are available at these vendors. I don't know if you guys ever noticed these going to India. Did any of you notice tobacco ads walking around? Yeah? Yeah.
Well, I noticed that in the films, if you watch a film on the DVD, they have a very long and kind of heavy advertisement, which is very graphic and very horrible against tobacco use. And this is something new because it wasn't so flagrant earlier. But when I tried to find a packet of BDs, not for myself, but for a friend.
Of course.
And I looked around. This was in Delhi, so perhaps it's different. But it was impossible to find a packet of beanies. The fellows weren't selling it. And he looked like I was, asking for something obscene.
Well, if you're at Han Market, maybe then,
Yeah, which part of Delhi were you in?
Where you were, right?
Well, I was in, around Pandara Road. But finally I found one guy and he said, okay, take this. And I said, how much do I pay you? And he said, take it free.
Free.
It was like, obvious I was not. So it's, but I'm surprised you say that, pan, you classify it in that. Of course, it depends on the degree of that supari, etc., which is in it.
Yeah, some people
But,
choose to.
Some pans are quite harmless.
Yeah, you don't have to have tobacco in your pan. And when I chew pan, I don't get tobacco in it.
Yeah.
But I think it's the availability of that. It's pretty high, and people, many do buy it with tobacco and betel nut. So this is a tobacco ad at a vendor location, this marquee. So a lot of tobacco companies in India are giving money to a vendor to place these. And the law says you can have 2 ads at a point of sale, we call them. And the ads have to be a certain size, 90 by 60 centimeters. Is this 90 by 60 centimeters? No, some would argue that it is because they believe this is the ad, this little thing, but it actually spans the whole marquee, which you can see from many, many feet away. Right? So this was common strategy for going around the law. You can only have the product name and brand, person, or anything like that on an ad. So this is violating that law as well by placing a man on the ad, a sophisticated urban guy, right? Here's another example, 2 ads. Another example of an ad at a vendor location. So, the laws are trying to restrict what you do at points of sale, which is kind of one of the newer areas of kind of regulating tobacco access, is to regulate the point of sale. And what do we find? We found that student tobacco use was related to vendor density, tobacco vendor density, within 100, no, my bad, I'm sorry. Student tobacco use was related to ad density within 100 meters. So ever using smoking tobacco, and currently meaning you used smokeless tobacco within the last 30 days, and any form of tobacco. These are what we call tertiles of density of ads within 100 meters. So the highest density tertile, you were at higher risk of reporting that you used tobacco. Right? And there was no relationship between vendor density. So we found that ads seem to be more important than actually a vendor of tobacco. So tobacco promoting messages seem to be more correlated with higher risk of tobacco consumption than actually availability. In terms of 500 meters, having a higher density of ads in the 500-meter radius was linked to ever smoking, but not currently using. And vendors within 500 meters was linked to currently using smokeless tobacco. So we kind of think that kids may not be buying tobacco within a small area of their school. They may be buying it a little bit further away, so others don't see them, especially their teachers or other parents. So that might be why we didn't see the effect in the 100-meter area. And this also speaks to maybe regulating it differently. Maybe you want to increase the radius around schools where tobacco can be sold from 100 meters to 500 meters. In terms of compliance to laws, these are the different point of sale laws that we looked at. We asked vendors if they did not sell to minors. We didn't do any type of check, an objective measurement. So 80% reported they did not sell to minors. 11% had a signage that said you can't sell to minors. 84% had fewer than 2 ads, which is compliant with the law, and so forth. So there was relatively high degree of compliance with most laws, except ban on this, the signage on the ban to sell to minors. But only 3% was adherent to all laws, and most of it is driven by having this sign in place. Right. And what affected compliance at the vendor level? The amount of money you earn from tobacco actually increased your likelihood of being compliant with the signage law, but it also decreased your risk of likelihood of being compliant with laws around ads. So the more revenue you had from tobacco, the less likely you were going to be compliant with laws around ads. And knowledge about fines seems to be a very important predictor of being compliant. So if you get vendors to be more knowledgeable about the fines associated with breaking laws, you may be able to increase compliance. So implications, point of sale tobacco control policy adherence needs to be increased in India quite a bit, and a lot of vendor education may need to happen. There may also need to be a culture of compliance to develop in India, where it's a normative to be compliant with tobacco control laws and other laws, and also a culture of enforcement. It needs to be in place in India that it does not exist right now. Educating vendors about laws and associated fines may be helpful, and reducing density of ads and locations where you can buy tobacco may improve, reduce tobacco use risk in youth. So as a whole, this is what we will see if nothing happens in terms of tobacco consumption prevalence around the world in the next 100 years, right? From now to 100 years from now, about 1 billion people will die from tobacco consumption. If you reduce tobacco consumption rate in youth by 50%, you will bring this curve down significantly. And on top of that, if you reduce adult consumption rates by 50%, we'll see a much more dramatic decrease in mortality rates in that. Probably about 50 to 60% decrease in the expected percentage of people who will die from, number of people who will die from tobacco use. So timing, we have to start early, and we have to identify strategies that work the best and get them in the hands of tobacco control advocates and policymakers. Thank you, everyone, for listening and having me here.
Take some questions?
Yes, of course.
I enjoyed that, Ritesh. So I was thinking, forgot about that. You mentioned that things like malaria, HIV, malnutrition. Those have been the more patronized by outside donors issues, and you don't have a Bill Gates Foundation targeting youth consumption of tobacco. But it seems to me that malaria and AIDS and all of that aren't tangled up with the commercial economy in quite the same way that a product is. And I wonder if you could just speak about whether the difficulty of regulation has something to do with the. I mean, you were pointing that way, but in what ways does the fact that tobacco is a commercially valuable good complicate its regulation in India, and if that's any different than, let's say, in Los Angeles, California, or?
I think it does complicate regulation. India, in one hand, is trying to control, the government of India is trying to control tobacco consumption. But with the other hand, they're supporting research on how to grow tobacco better, right? So the Department of Agriculture is funding tobacco agriculturalists and scientists to identify ways to increase yield per hectare. So there is a competing interest within the government itself about what to do about this specific product that has a lot of value for business and economy, and at the same time is hurting the population. So there are lobbyists from both sides trying to work with legislatures to diminish or increase tobacco control efforts. For example, the law on not selling tobacco within 100 meters of schools, that was vigorously debated at the federal level. And I think the radius was supposed to be higher, but the tobacco companies did what we did. They mapped out all vendors in a place like Mumbai and said, if the radius is maybe 500 meters, the only place we can sell tobacco is in the ocean. Yeah, right? That's right. And so for the freedom of expression, it is our constitutional right to be able to sell tobacco somewhere if we wanted to. So there is a tension, definitely. And the other piece is, I think, behaviors like tobacco, like diet, like physical activity, things like that, drug use, there's a sense that it's a personal responsibility, right? Things like malaria, people they may not put an individual responsible for contracting malaria. It's because of a mosquito that's out there that needs to be controlled. And that might be another reason why people are more willing to fund malaria prevention or control efforts rather than tobacco control efforts. Also to say that the Bloomberg Foundation does fund a lot of tobacco control efforts around the country and around India and around the world. So Bloomberg is very heavily focused in tobacco control. Yeah.
Well, thanks for this. I was a bit nervous about coming and listening to this because the subject kind of difficult. One question, what happens when you produce a report like this? What happens to the data you've collected? How is it used? And what is, does it have an impact on? And then I was wondering, some of the advertisements you were showing us, Gold Flake, etc., Marlboro, these are big companies. And so you have a lot of advertisements, but as you pointed out, a lot of tobacco use is, in the intimate, private space, and then people make their own forms or packages, and this is all in the home. So on the one hand, you can have a public regulation policy, you can have norms, you can have rules, you can have fines. But how do you deal with these private practices? They're rooted in cultural traditions, hookah, then women take various forms of tobacco.
Mm-hmm.
So is there a different approach and thinking about that? How is one going to tackle that? And are states, for example, sensitive to this? Do they include it? Like, for example, there's now a great deal of publicity given to, setting up toilets, sanitation. So is there a publicity given to this issue in India by local organizations, NGOs, the government, state parties, etc.?
Yeah. Well, for your first question, how is this data used? We did develop a report, fact sheets from our student survey in India, and shared it with the educational ministry in Mumbai. We do share our data with tobacco control advocates in India. The group that I worked with in India are leaders in tobacco control research and advocacy. So they do run advocacy forums and meetings on a regular basis that work to develop messages for legislature around policy changes. So the issue around how ad laws have been circumvented are becoming more and more apparent now through research and journalistic articles around the issue. So we share the data that way. And I think what happens with a lot of public health research, it's one piece is not going to do it all. It kind of is, you put all the research together to develop advocacy efforts around tobacco control. So we try to share our data with people who are working with policymakers or lobbying for tobacco control efforts. Now, in terms of controlling what happens maybe in your own home around making your own, rolling your own cigarette or other forms of tobacco, I think the tobacco control community is not as focused on that. I think they're more focused, we are more focused on the marketing of tobacco widely. So if you first deal with that, which is probably the major contributor to consumption and consequences of tobacco use, you probably see a bigger benefit than spending more of your resources trying to control what might be happening, in your own home around making your products or growing your own tobacco or something like that. So I don't see that much focus in the area that you're talking about. But I could be totally wrong.
Hi, I want to commend you on a really neat
tiny little study that has a lot of implications. I wanted to push you a little bit. So when you mentioned your implications, you focused on the enforcement and regulation aspect of it, and I agree that's huge. However, there is the health behavior aspect to it. In the US, you saw things like the Truth Campaign and things on TV that were a direct message to the target demographic that you're looking at. And I wonder what it would take to have some sort of impact in terms of health behavior in India. I mean, I'm not a fan of course, social stigma of any kind, but you'd be hard-pressed to find a youth in the US who wants to date somebody who smokes. You know, it's no longer cool, right? So that peer pressure that you see in the US to not smoke or use tobacco products, what do you think it'll take to have something like that in India?
That's a good question. I think the reason Americans believe it's not cool to smoke in public, or you may not want to date somebody who smokes if you're a teenager, I think a lot of that has to do with tobacco control legislation in this country. Smoke-free laws did a lot about denormalizing tobacco consumption. It became kind of uncool to smoke after you started having smoke-free laws becoming more and more common. So I think having good legislation that kind of changes the normative environment or legislative strategies are probably more powerful in changing normative environments than maybe just health education types of efforts. The problem with India, the Indian experience, is that it's probably more of a top-down effort in tobacco control. From what I understand in the States, especially in California, which is one of the forerunners in tobacco control efforts, it was more of a grassroots effort that built in California's tobacco control agenda at the policy level. So that may have resulted in some of the norm changes that you're talking about, that it was more of a grassroots effort. In India, it's more of a top-down effort. So you may see a lot more resistance and slower adoption of policies and kind of the normative concept that are driving those policies. But I don't believe that you should just do one or the other. You kind of have to do all of these things together. Things like the Truth Campaign were great, and if India had a similar campaign, I think it would have some benefit in conjunction with policy. And there is not that much tobacco control education in schools in India. That's right. So I mean, there's just probably so many different things that need to be done, and tobacco is probably not the priority. Yeah.
An example of top-down legislation is against dowry. There was so much of that, and it didn't help at all. So, I mean, do you think top-down legislation is just being imposed?
No, I think it's a problem. That's what, it may take a long time for India to see some of the same kind of normative issues that we have here on tobacco because of the top-down approach. Yeah.
So you mentioned that there was a great variety of many circumstances in Mumbai, including economic. And so I was kind of wondering about the sample of the schools, what they were like, what communities they were in, and if that showed any interesting results in what you found in terms of tobacco use or vendors and signage and so forth.
Yeah, so we did a population-based kind of a sample to have a representative sample of students in Mumbai. So we had some of the schools were in Juhu, right, which is where the stars live, or Bandra West, and some of them were slums. So we had schools in all socioeconomic status communities in the sample. And what we did look at that as a predictor of tobacco use and compliance. And I don't think we saw any effects on using tobacco, but they were the higher socioeconomic status schools were less compliant with tobacco control laws. So there was a negative correlation or relationship. Um, I don't know why, but that's what we found. Yeah.
Hi, it was a very nice presentation.
Thank
Thanks.
you.
Yeah, I'm Cliff Douglas.
Hi, Cliff.
We haven't had the chance to meet yet. I
Yeah,
don't
he's
think,
a public
but
health guy right there.
We work on tobacco.
Yeah.
There's a new piece out in the British Medical Journal, and I was wondering about any reactions you might have to it, because it suggests some reason for optimism, but it all comes down to actually, effectuating the kinds of proposals that have been made. But a couple of things. A new bill has been tabled, apparently at, I guess, the National, the Parliament or Legislature, that would extend India's ban on smoking in public places to include restaurants and hotels. I guess if restaurants are not covered, they're not covered completely, but this suggests that there's a gap there to be filled. And I see. So that they would no longer be permitted to have designated smoking areas.
right.
That's
That's
the
the
distinction
issue.
that we've dealt with quite a bit here
Yeah.
for, as you were, for a number of years. And tobacco products could no longer be sold as loosies, as single cigarettes, so that they wouldn't be as cheap, and that avoids having warning labels attached to them as well. And then the ban on tobacco advertising would be extended to include the point of sale, so that 2 or fewer ads would, at least under that law, would no longer be prevalent. And there's some other changes
right.
too. So it's exciting, and it reflects, as you were highlighting, the kinds of guidelines that we see in the Framework Convention on Tobacco Control. But I wonder about, you have much greater insight into the feasibility of moving these kinds of pretty significant changes through the political system there. And, going back to an earlier question, the tobacco lobby is enormously powerful. And I like hearing about malaria, because we say half jokingly, malaria doesn't have this well-organized, well-financed, organization made up of mosquitoes fighting for their right to continue to spread the disease. But tobacco, on the other hand, has billions at its disposal worldwide.
right.
So, any thoughts you have about any of those things?
Well, it's a lot of things, but I don't know about how those bills will make it through the legislature in India or the parliament. To be honest, I'm not so savvy on how that works out in India. I think these are all important bills. I do believe the point of sale bans probably won't make it through, because that is a pretty strong restriction on advertising. Basically, that means you can't really advertise anywhere if that happens.
Which is what some countries do,
Are
not here
doing.
because of our First Amendment, but in other places it's
That's
just
right.
disallowed.
That's
Yeah.
right. So it'll be interesting to see what happens around that. Yeah, I don't know what's going to happen. I mean, I don't have the pulse, about those things. And I think some of these things have been introduced, failed, or being reintroduced again and again. So maybe the Parliament is ready under the new leadership to take this on. Yeah.
So Ritesh, thanks so much for coming in and talking to us. I appreciate the fact that you recognize that some things that maybe a public health audience wouldn't know about, those of us might know about here, but obviously we may not know the public health side of it. And I feel like some of the questions already have been hinting at this, so I kind of want to put it out there with some more clarity, which is that the framework that you're presenting here is about this WHO global standard for how to deal with tobacco use. And many of the practices that you're pointing to in India, I mean, we have global smoking, right? But we have a lot of very particular practices in India as well. So I guess the way to frame my question is, to what extent do you think that this global framework is, is it the effective approach? Is it the only approach from a public health perspective? How does one deal with the specificity of India in any way as you think about policy, implications from your work? Or does one really think about, like, there's this global framework and this is how we, is the attempt to prevent youth tobacco use in LA and Mumbai the same, for example? I mean, I guess that's maybe what I'm trying to suss out a little bit today, is to what extent, when I think about youth tobacco use, I actually wonder how effective are those ads in getting kids to smoke. It seems like you're drawing correlations between removing the ads and diminishing smoking, but can we get at this is a slightly different question, can we get at some of the more qualitative aspects of why so much youth is turning to tobacco use, which kind of links up to Apurva's question a little bit.
Yeah, I don't think the framework convention is the cure-all.
Yeah.
I think it probably is a guiding kind of, document and a set of strategies for a variety of different cultures to adopt. And all the strategies on there are not necessarily evidence-based. It's more maybe a consensus around some folks developing the articles of the convention framework. And a lot of it is about also promoting research and communication around tobacco prevention and control, to learn more about what might be happening in the setting, in the specific cultural or economic setting. So I don't think it's supposed to be one approach for everybody. I think the idea is for everybody to pay attention and to kind of also understand that these are some things that seem to have worked in some countries. Why don't those that don't have legislation around these things adopt them as well? The other piece is, what we look at a lot is how much can we explain variability in health outcomes or behavioral outcomes by looking at a variety of factors that may be causal to that. Tobacco control laws do not 100% predict consumption behavior, right? There are other things that drive people to use tobacco or other drugs or other substances. And those also need to be addressed, those things that could be around, coping with stress or distress, maybe having some issues within the family system that may not be working, so people are using tobacco as a coping mechanism. There could be cultural forces that may drive people to use tobacco that have nothing to do with any of the above.
So just maybe like one follow-up question
Yeah.
would be, could you point, since you have experience of working in the U.S. on this issue and working in India on this issue, could you just point us to what you saw as maybe the most glaring kind of similarity? But I guess I'm more interested in thinking about, did anything strike you as really different as you were thinking through this question of youth and tobacco, control?
Well, one simple thing is only about 50% of kids go to school in India. So a lot of tobacco control prevention education in the States happens in schools. So school-based studies are not the way to go if you want to do youth-based tobacco prevention and control in India. The other thing is just the amount of exposure you have to a product like tobacco is exponential compared to here. So I don't know what that really means in terms of your risk of taking that on as what you want to do in your life. It's just dramatic.
Is there any stigma at all attached to tobacco use in India? Going back to an earlier, the normalization versus denormalization, because that's so critical to what the behavior ends up looking like.
I think it's different for different products and different classes. Cigarettes are becoming more cool for women to use, young women to use in India, just like it was here years ago. So, you know, and BDs are not cool to use by certain socioeconomic classes. I think chewing, like pon or stuff like that, is very normal. And a lot of stuff, I think, it happens in college-age kids. Here, maybe a lot of the initiation happens in high school. A lot of initiation in India around tobacco seems to happen in college. And I think it starts with ban masala and then goes forward. So I think it is not stigmatized as much as it is here. The spitting issue could be stigmatized somehow. You know, maybe if there was a great campaign to get people to stigmatize spitting in public places, that may have a dramatic impact on chewing. Yeah.
Yeah, there's a lot of no spitting.
There is.
This new legislation addresses spitting.
It does. I have to read this.
The draft bill I'm just reading recognized that tobacco spitting was implicated in the spread of several diseases and outlined plans to ban this practice in areas where smoking tobacco is banned. And then it's consistent with the government's, I'm not going to pronounce it correctly, well, it's the Clean India Mission, the Swachh Bharat Abhiyan, launched last year to promote better sanitation and hygiene. So it's being...
And I think that's Modi's major effort, right? He wants to clean up India like he tried to do in Gujarat. So that's great. Thank you.
I wanted to go on this vein where I don't want to look at the differences in the means, but I want to look at differences in the ends. Because I'm suspicious, I'm building on where Farina was going, of international regimes.
Mm-hmm.
And somehow there's something that says that tobacco use is bad. This isn't contested anywhere. So I don't know exactly why tobacco use is dead in different places where death has different values and where suffering has different values. Now, I don't understand how bans on tobacco use don't come out of a Protestant ethic. An ethic that you find it in other religions where the idea is to suffer or to be ascetic, and this is a moral quality. And I don't think we find this widespread in much of India. If you start talking to people about traffic deaths and road behavior, you find, I think, much more there than other places, a sense that when your time is up, and it doesn't matter how you behave. I'm wondering why we're not taking certain things into account. I don't know what's wrong with tobacco use. I know what's wrong with tobacco use in relationship to certain values which put life over death or which put pleasure over suffering. But I don't understand, why it's so bad outside of some very particular international regime.
Which places value on life.
On long life, right.
Long life over death.
Right. I mean, this is, if we would do nothing about malaria and these other diseases, this wouldn't be a problem at all. Your whole thing, your whole first graph on these temporal things doesn't control for life expectancy. I mean, once you start cancer and heart and coronary disease are diseases of old people for the most part, statistically. So of course they're going to increase,
as life
goes
Sure.
on.
Sure.
But, what's so good about long life outside of a certain value system? So in some sense, I know I'm coming from left field. I know public health is
Sure.
based on a
Sure.
different value system.
Sure.
But if we're to be sensitive to other environments and suspend some of the values that we take for granted and think that in other ways of life there may be other values,
So,
I don't know. I'm just going to.
I know nobody was going to go that far.
No, that's fine, Lee, but I'm not sure that also that kind of insinuates the possibility.
Well, if you
Certainly in my experience of India, I don't see many people valorizing not life. So I don't know where your argument is coming from, so.
No, it's not valorizing not life. It's not valorizing this life because there's another life to come and a life after that to come.
I don't know, that might be.
And people do talk this way.
they do, but I guess if you want to talk about the next life, you want to get to your next life more quickly. I don't know. I mean,
Well,
I guess what's the alternative? Give me an example of a different value system that may exist in India, and how would you deal with or not deal with tobacco or any kind of behavior that may cause suffering or early death within that life value
it's-
system?
in
Because
some
it seems too abstract to me what you're putting forward for me to respond
Let's
to.
start talking about alcohol.
Okay.
There's tremendous pleasure with it. There's tremendous pleasure with tobacco. There's tremendous pleasure with driving a motorcycle quickly and perhaps without a helmet.
Okay.
And so if life is about, and it also, contributes to certain forms of social solidarity
Sure.
and exchange and conviviality.
Okay.
And so these values somehow exist with other values about life and about non-pain and things like that. And so there are scales of priorities
Sure.
here. And I mean, in everyday behavior, we all do it. If we didn't, public health would go out of business.
Well, I guess I think
so
these
I ju-
types of, for tobacco control policy or alcohol
Mm-hmm.
control, do you want to leave a room for personal freedom, right?
Why? I don't understand this, this tremendous insistence that the West has the ultimate values.
Well, it's
It
not
just
just the
bugs me.
Western value, I don't think. Go ahead.
What, personal freedom is, I mean, where did you get the notion of personal freedom from? Where will you find personal freedom, within an Indic culture? I mean, I know about Swatantra, I know about, Swaraj, but this is not personal freedom. So, I mean, it's at that level. I mean,
Sure,
it's just
sure.
a matter, and if we're coming in, the international regime is coming in with a program. And it just seems that needs to be recognized.
Yeah, I guess I haven't thought deeply about what you're bringing up, so I may need to. You have a response?
One of the basic things that transformed the approach to dealing with cigarette smoking in particular in the U.S., starting in the 80s, which is what you were addressing earlier, which was the advent of smoke-free policies in workplaces and then restaurants and even more recently bars. And the reason was because of the fact as science came to understand that the smoking wasn't only harming the individual user, but it was harming the community. It was causing sickness and even death, and widespread death, in innocent bystanders. And so there is a larger communal value that has really become critical at least in the way that we have viewed it. And, well, enjoyment is... You can talk about enjoyment, but a lot of the enjoyment, if you want to really get scientific about it, in the use of tobacco has to do with the addictiveness of it and avoiding withdrawal symptoms when you don't use it. That's an enjoyment, quote unquote, that results from the medical problem that you got into in the first place. But the communal value has to do with the fact that a lot of people are innocently exposed if policy doesn't prevent it or individual respectful behavior doesn't prevent it, to a lethal substance that's airborne. So that's a big issue that's come into play, and it goes well beyond the concept of individual enjoyment or individual liberty, and there are many ways. The traffic laws are all about controlling and managing what can be a dangerous activity. We have the right to drive, but we don't have the privilege to drive beyond a certain speed limit legally or do other things with our cars or firearms or motorcycles or whatever. But tobacco is sort of the quintessential example where there is a need to have some control and management in the broader interest of the well-being and welfare of the community, not only the individual's activity.
I think the other issue is also, there is also ritualistic use of substances like tobacco, which are not necessarily addictive use. The Native American culture used tobacco for hundreds of years for ritualistic practices. But what's happening now around the issue around tobacco is it's a capitalist business market that's pushing this substance in many ways into the hands of people and maybe promoting addictive behavior around this substance. And so so the value that's driving tobacco consumption is not communalism or pleasure. It's so what the public health community tries to do is try to work against this kind of force that's putting this product in the hands of people who may not choose to have it otherwise if left on their own devices. Does that make sense? So, so it's not putting pleasure over pain or pain over pleasure. I think it's about, anyways.
Can I ask?
Maybe a final question. Yeah.
Okay, just a small thing. You know, all this discussion makes me wonder if in your public health group, you must have anthropologists working on these questions along with you? Because I asked
we
that
wish
because
we
in
did.
France, I'm sorry?
We wish we did.
Yes, because in France, actually, a lot of anthropologists are now working very seriously to advise international organizations on how to effectively invest in public health policies, especially concerning in African countries, on how to deal with pregnancy deaths. And they find that a lot of attitudes of local people, women, towards going to hospitals and accepting help is linked to their cultural practices. And so they're working very closely with, in fact, now in France, you can't think of public health without thinking of the anthropologist's role. And some of the questions seem to, so I was wondering how it worked out here.
Well, the tobacco companies certainly hire anthropologists. The marketing companies certainly hire anthropologists.
Yeah,
They do.
They do. They're
part of what
figuring
they
that
do.
out really well.
I think for public health in the States, we have to work a lot harder to be more multidisciplinary and interdisciplinary. We do have anthropologists who may work with us in the School of Public Health, but they're a very small minority. And to be honest, I don't think they inform every research project that is put in place. So there needs to be a lot more communication across fields, definitely.
Ritesh, let me thank you for sharing this work with us. I really do appreciate it.
Thank you for having me.